Good afternoon and welcome to today's presentation, Transforming Data into Information Using Standard Quality Measures, Part 1. My name is Keelan Henderson and I'll be your facilitator today. At this time, all attendee lines are muted for this session. To minimize background noise and distractions, we encourage your questions and input throughout this presentation. Excuse us, I'm sorry. Wait, we're in a hospital, so that's going to happen. So please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation is being recorded and later uploaded to our Health Vision Zamara PTN YouTube channel. We ask everyone to visit this channel simply by going to YouTube and searching Health Vision Zamara PTN. You can also subscribe to this channel and even get post notifications as we upload more content. I'd now like to introduce you to our speakers for today. Our first speaker is Barbara Vergrinick, MBA. Barbara's entire career has been in healthcare. She began her career in the hospital environment with over 20 years of experience in information systems, health information management, decision support systems, patient access, and patient business services. She was a Chief Information Officer, Vice President for over 10 years at BB Healthcare in Lewis, Delaware. Over the past 4 years, Barbara has worked in assisting physician offices with their EHRs, businesses, and transformation processes. She's worked as a project coordinator and practice transformation specialist at Quality Insights of Delaware. And Barbara is currently employed as Health Vision Zamara Senior Practice Advisor. Barbara participated as a board member for Delaware Health Information Network, the DIN, for 5 years. And she has her master's in business administration. She's passionate about improving healthcare and patient outcomes. Our second presenter today is Edward Sobel, CEO. Dr. Sobel is Health Vision Zamara PTN Medical Director. Dr. Sobel is also a retired family physician from the Family Practice Associates of Wilmington, Delaware. He is the Medical Director of Healthcare Quality Improvement Program for Quality Insights of Delaware, the state quality improvement organization. His areas of expertise include clinical quality improvement, evidence-based medicine, practice management, and electronic medical record systems implementation. Dr. Sobel is a senior attending in the Department of Family and Community Medicine, Christiana Healthcare Systems, Wilmington, Delaware. He is board certified in family practice after graduating from the University of Health Sciences College of Osteopathic Medicine in Kansas, Missouri in 1973, and completed an internship at Parkview Hospital in Philadelphia, PA. His awards include the 2001 Family Physician of the Year by the Delaware Academy of Family Physicians. He was a finalist of the 2010 HIMSS Nicholas E. Davies Award of Excellence and for recognized excellence in implementation and value from health information technology. And he received the 2011 Daniel A. Alvarez MD Service Award from the Medical Society of Delaware for helping implement over 1,000 physicians on electronic medical records. He currently serves as a precipitator for Department of Community and Health Medicine Residency Program. I'd like to thank both of our presenters today for their time, and I'm going to now pass the presentation over to Barbara.
Welcome, everyone. I see from my attendance listing that we have participants from the private physician practices. We have participants from ACOs and other healthcare support companies. I would like to welcome all of you, and I think you will get information out of this. First thing I want to talk to you about is learning objectives. Looking at you learning to understand the process of collecting structured and accurate data, to understand the concept of baseline, benchmarks, targets, and standards. I know a lot of times we come in and we collect baseline information from you guys, so I'm going to try to explain why we do that. To understand the MIPS quality measure specification, and to compare your practice quality measures against the 2016 benchmark. Our agenda will be, the first section I'll talk about would be transforming data into information. I will then turn it over to Dr. Sobel. Well, he'll talk why physicians hesitate to enter structured data. And then he'll hand it back over to me, and we'll talk about utilizing standard quality measures. And the last thing would be selecting measures and comparing them to the benchmark. While transforming data into information. Well, with the development of the EHRs, which has been over probably a 5-year process, many healthcare providers face the problem of having too much data, yet very, very little data information to enable effective decisions. In other words, and you probably heard this before, healthcare is a data-rich and information-poor industry. We have a lot of data, but to make decisions, you need information. Why is that? Healthcare data is complex. Currently, half of it or more is unstructured. Not only is the data unstructured, there are recordings, images, and legacy records collected in paper which may or may not be scanned into your system. So what is so important about structured data? Structured data, or natural language processing, is a requirement to turn data into information. Structured data is searchable, reportable, actionable, and interoperable, which then can be used to share data with other providers. Structured data is well informed and codified using the clinical concepts containing IC9, IC10, CPT4, LINK codes, and SNOMED, and other various codes. What is so important, again, continued, about structured data? Well, meaningful use, stage 2 requires providers to exchange data, not using faxes or free text from transcription systems, but to transfer data using HL7 messaging. And again, that's more of an IT way of doing it. An example of this is exchanging a summary care record. We have now moved into, instead of sending faxes, is actually sending a summary care record. It is not possible to perform clinical analytics on unstructured data. You got to have structured data to do that. EHR entry provides structured formats for entering data, but many physicians hesitate to use it for patient documentation. A lot of physicians like to actually dictate their notes, H&P and discharge summary, etc. 5 tips to help you collect useful structured data. Collect only the useful data. Select those structured data that has some meaning to your practice. We always say that if you're going to select a measure, select something that means something to you. If you're endocrinologist, that you may want to select a measure that is dealing with diabetes. Collect accurate data. Ensure good data is being captured in the correct area of the EHR so that measures are accurate. This is where a lot of practices are struggling. They don't know from their EHR vendor where they should be entering information. And if it's not in the right field, it's not being captured in that measure. Convert data to information. Take your measure data and analyze it and trend it over time. You need to make sure it's accurate, and then you can actually convert that and look at the information and see if you're improving on that specific measure. Use analytical tools. Use quality measures in order to understand where your practice stands. And a lot of times what we say is, look at that percentage. Does that represent what you think is going on in your practice? And then make decisions using information. Look at the specific measure and ask yourself, again, is this applicable to what I think my performance is? If not, you're probably not capturing accurate data. And so you need to really work with your EHR vendor and to instruct you on how to capture that measure information. Now I'm going to turn it back over to Caitlin, and she's going to do a polling question.
Thank you, Barb. Our first polling question, which should come up live, is, I'm sorry, can you use this? In most EHRs, what percentage of data is entered is not structured data? Let's go ahead and launch that. I'm sorry, it didn't look like it was launching. Okay, in most EHRs, what percentage of data that is entered is not structured data? Give it a minute, try to get everyone to vote. and about 55% voted. Let's see if we can get everyone to participate in this poll. Okay, 10 more seconds. Let's go. Okay, I'm going to close the poll and I'll share those results. We had 0%, or I'm sorry, we had 4% say 0%, 37% said 25%, 26% said 50%, 33% said 75%, and 0 said 100%.
That's about where everything looks like it should be. Most journals say it's over 50% or under 50% that's not structured. So I think it's a good number.
Yeah. Okay. At this time, I'm going to transfer the presentation over to Dr. Sobel.
Good afternoon, everyone. Caitlin, let's see, I lost my picture.
Lost your picture. Let's try again. I'm sorry, I don't know. It says you have the screen, Dr. Sobel. Do you want to try giving me back the control?
Yep.
Oh, I see your screen now.
Yeah, but I don't see the presentation.
You don't have it up?
Nope.
Oh, okay. Well, how about this? Go ahead and give me back controls, and I will, if you don't mind just telling me next slide.
Okay. I'm trying to give you control.
What do you have on your desktop?
Yeah. It's not letting me, let's see, not letting me give you back control.
Okay, hold on, let's try this. Okay, how about now?
Yeah, I can see the slides now.
Okay, go ahead and just tell me. I'll run your slide deck. I apologize, everyone.
Okay, not a problem. Okay, so structured data is really important because that's really the only thing that the computer can see, and we're going to talk about that in a minute. So how come we don't use structured data? Now the slide says, why do physicians hesitate to provide structured data? A lot of physicians like to dictate, and it's just kind of the way they've always done it. They like a narrative, but narratives are generally not picked up. Most EHRs will not pick up natural language. They need to look for a certain place on the chart. We're going to look at that in a few minutes. A lot of clinicians don't understand the reasons why using structured data is important, and that really helps the practice if we structure the data. A lot of physicians tell me they hate clicking the box. They just feel like it's too restrictive. They get inadequate choices. Cookbook medicine is another phrase that I hear all the time. I'm just being forced to do things the way the computer company wants me to do it, and I hate that. And lastly, they'll say it takes too much time during the patient's visits, although if done correctly, really, you can get a lot of information done with one click rather than typing a whole lot, and that's probably really good for clinicians who have difficulty typing. Okay, next slide. All right, so here's really the key slide that talks about why we want to have structured data. And this is from an Allscripts EHR, but just this works for pretty much anybody's EHR. And this is what's called reporting module, or how do I find out about my patients? Now you can see the screen is divided into two sections. The bottom section where all of the reports, and these are reports that the system will generate, those are provided by the vendor, and typically vendor-provided reports have to do with measurements like PQRS, meaningful use, patient-centered medical home, and the things that normally a practice needs to report for quality measures. The blue reports up above that are reports that the practice has actually created and use for their own internal purposes to provide better patient care, find out more about their patients. So I always say the reason you buy an EHR is so that you can get something like reporting module. And I have to frankly admit that when we bought the system in our practice, which is now 11 years ago, I didn't understand this. Everybody wants a system that basically, how do I document a visit and how do I bill for that visit, and everything else is kind of secondary. But this is really one of the two keys. The other key we're going to talk about in a few minutes. So reporting is the key to taking better care of your patients. Next slide. And this is typically what a report looks like, and just for the purposes of understanding the report, this report looks at, for instance, all active Medicare patients under the segment section here, all active. So we've already done work behind the scenes to select only our active Medicare patients. So we eliminate patients who have passed away, patients no longer in the practice, and so forth. And what do we want to know about these patients? We want to know which of the patients are diabetic and which have been seen in the last year. And so we set this up with an active problem using ICD-9 or 10, depending on the system, with a listing of all patients who have diabetes. You can kind of see that out here at the bottom in a spelled out form. And then we put in here patients who have had a visit in the last year. And so if I were to hit the OK button on this report, the system would grind for a few seconds and then would produce a list of all patients who have been seen, who are Medicare patients, who have Medicare insurance, and who have been seen in the last year. Now, that kind of might be nice to know, but what would really be nice to know is give me a list of all my Medicare patients who are diabetic but who have not been seen, let's say, in the last year. And so I could go in and modify this block called last year and click in there, and it would switch the report from patients seen in the last year, not seen in the last year, which means where are these patients, how come they haven't been back? And I can adjust the time frame. So it really begins to give me a way of reporting on my patients, of finding out about my patients, of using my data. All clinicians, when you go in and you say, how's the care you give your patients? I haven't met a clinician yet who tells me that all of their patients above 6 months old he guarantees or she guarantees they've had a flu shot. Everybody over 50 has already had their screening colonoscopy, and all women who are eligible have had a screening mammogram. And when you get the report from your insurance company and says, well, those numbers aren't exactly right, the typical reaction from a clinician is, well, the insurance company's data is wrong. But when you run your own data, you kind of find out that maybe that's a little far from the truth. So really gives you the opportunity to take this data and use it within your practice. Okay, next slide. What can you do with the data when you generate a report? Okay, so in this case, if we ran the report, we could set up to put a reminder automatically into the patient chart. Just in case you're wondering, these are test patients, so there's no HIPAA violation here. These are not real patients. But we could put, for instance, a reminder in the chart so that every time the chart is opened up, we get a pop-up message. In this case, it says this patient is over age 50, and the report that we used to generate it took all patients who are over age 50, took away all the patients who have had a colonoscopy, who have had colon cancer, who otherwise would not be appropriate for screening, and then those remaining get this pop-up message. So each time is an opportunity for the clinician to say to the patient, you really need to get colon cancer screening. True value. And when you do this, it's amazing. Just that simple reminder doesn't take long. And in fact, in a lot of practices, this really gets left to the nurse or the MA to talk to the patient about it, remind them, give them the literature, so that by the time the clinician gets in there, the patients have been kind of greased already, I hate to use that term with a colonoscopy, to be prepared to have the discussion and go from there. So very little clinician time taken up in order to get the patient to do a better job in taking care of their health. Next slide. So why do these reports fail? Okay, what can be internal problems that go wrong? So here's another slide uh, of a shot of an immunization. So the practice records immunizations each time one is given. The staff puts in uh, the information. This one doesn't show up, and the reason it doesn't show up when we run a report is up here is refused date, and the date box is very important. The fact that this date box is empty, the system can't see it. Putting the date box, and you'll commonly see it, and I've seen it down here in the comments box, is useless. So we'll often see the date down here. But in all of these screening efforts, using putting the comments, putting the data in the comments or other area doesn't work. Must be up at the top in the date box. Okay, next slide. Here's one, and actually this one in particular, the vendor, in my estimation, has made a mistake because this is mammogram screening. So we're going to document mammogram screening that's done at the top. But if you look in the details box, highlighted in gray, it says insert date into details. So if you go ahead and down under attributes, you insert the date there because it says to insert the date down there. So in this case, the date is 2013, and you think you've done a great job. The reality, this screening mammogram will not be seen when you do a history or do a report for that, because the date needs to be where? In that date box in the upper right corner. Without a date up in that upper right corner, not going to be seen. The other thing that sometimes gets us in trouble, if you look just behind this pop-up where there's health maintenance highlighted, that's actually where screening mammograms go. But you'll see underneath that diagnostic studies. And I've seen in practices where screening mammograms get put into that diagnostic studies. And a screening mammogram is not a diagnostic study, it's a screening exam. So you have to kind of be careful in where this data gets put within the system. And these are things you need to work with the vendor in getting that done. Let's go to the next slide. Now, here's laboratory reports. This is a real report from a real patient. Came in from LabCorp, and it gets scanned into the computer. Scan reports are like pictures of your grandmother. They're in a photo album somewhere, but you never get to see them again unless you open up the photo album and go searching through to find grandma's picture. So it's really useless data, and it doesn't help you to take care of patients. Ideally, data needs to come in digitally because then it can go into the system, and digital data is retrievable. Next slide. So here, in fact, is digital data. This is a hepatic liver function panel coming in to the practice from the DIN, and the results are here. And so now this becomes an opportunity to use data. And I just can't strongly recommend that if you aren't connected to DIN or your HIE in your state and getting all your data electronically, it's like today's mission to get done before 3 o'clock. Next slide. Okay, and here's the value of DIN. When data comes in digitally, it automatically goes into this system, and then you can go ahead in a lot of systems and actually plot the data. So looking at the graph there, and this pops up literally 2 seconds after you hit a button, not commonly. This is a great demonstrator for the patient. Okay, this is the patient's hemoglobin A1Cs, and this is a real patient. And you can see starting way back, this patient has run a hemoglobin A1C 10, 11, at best got down to 8.5 for years. Okay, and so, you know, eventually you read the Riot Act, you talk to the patient, and lo and behold, you know, somewhere the patient got the message, and you can see the last hemoglobin A1C has dropped significantly. We're down to looks like about a 6 or 5 down there, but you know, very obvious. What a great teaching tool to use for the patient versus just haranguing them that they're not doing well. Same thing, you can do a report if your data is in there digitally. Give me a list of all my patients who have a hemoglobin A1C over, let's say, 8. there's no sense in chasing down your patients who have hemoglobin A1Cs at 5.6 or 6.5, or maybe even 7.5. Those are under control. So if you really want to focus on your diabetics who are not in control, the ability to have digital data, the ability to extract it with a report internally for your use, gives you an opportunity to bring the patient in and work with the patient, try to figure out why their hemoglobin A1C is 12 at the last visit, and then work with them to get it down. I would encourage you, if you're not using your HIE, if you're not using your electronic information, it's really the way to go. Next slide. It's going to give us the polling question, so that's back to you, Caitlin.
Thank you. The next polling question. Structured data is important in an EHR because A, it's searchable, reportable, actionable, and interoperable. B, analytics can only be performed on structured data. C, structured data is more easily added by dictation. D, meaningful information can be captured through structured data. Or E, A, B, and D. Get a couple more people to vote. I'm going to go ahead and close this one. Everyone seems to be in consensus. And share those results. Oh, I got a little bit changed, but 96% said A, B, and D.
Correct. That's what it is. That's the correct answer. Thank you.
I'm going to go ahead and hide this, and I'm going to turn the presentation back over to Barb.
Okay, why should we use standard quality measures? Actually, quality measures are a means to take kind of like the pulse on how your practice is performing on specific diseases or processes. You can compare your scores to the benchmark in order to see if improvements are needed. This is important because basically if you want to compare yourself to other practices, whether specialty to specialty or private practice to other private practice, family practice, it's nice to see the data and how you are comparing it. And that's what CMS is doing with all these changes now. For 2017, CMS has released 273 quality measures. And really that's not enough. I mean, I still have specialty practices that look at the quality measures and do not see something specific to their specialty. But at least it's increasing over the years. Each measure has a different specification, codes, and reporting options. I know it's really difficult to look at those specification sheets because some of them go from 5 pages to about 10 to 15, and it's very hard to look at them and understand what they're trying to get at. But to find out what data is captured in a measure, go to qpp/cms/gov and look in the last section of the site under education and look for the 2017 measure specification. All those, whatever measure you pick, you can go out there and you can see what specifically is being captured, at least according to the measure's requirement. Choose the measure and the way you will be submitting your data. You will see that the measure is repeated a couple times. It will have, depending upon how you're submitting it. Your measures will be submitted to claims, the EHR, or the registry. What are benchmarks, baseline targets, and standards? Well, if you're one of the Health Vision Delmarva practices, remember when we came in and we first said to you, we'd like to get some baseline information. What we ended up doing is looking at measures and asking you to collect information or show us information for a period of a year. And then that would be our starting point for comparison. So it's almost like starting off with, okay, this is where we're at, and we want to look on a quarterly basis where we're going to be. A baseline for your performance measure is the average level of performance that you are currently at. The same thing came up when we talked to you about a baseline assessment. When we're working with you, we started with a baseline assessment, and then every 6 months or even more frequently, we would actually reassess you and take a look at what improvements we've made. Measures are similar to those assessments. What is a performance benchmark? A point of reference in which things can be compared or assessed. If you look at, again, at the measure benchmarks, and you look at your measures, you can see differences and see where you need to improve on. What is a performance baseline? A minimum or starting point for comparison. I'm sorry. Sorry about that. What is a performance target? A level of performance that you are aiming to reach in the future. You know, everybody, for example, if your A1C is for a patient is at, say, 9, you definitely want to get it down. So you definitely want to monitor what's going on, and you want to bring your A1C down. To shift a baseline performance level to a targeted performance level takes time, and this is just not for a patient. This is basically for your practice. You have to redesign the underlying processes capable to perform to better performance. It doesn't happen overnight. You may have to actually use PDSA, which is Plan, Do, Study, Act, quality improvement process, to actually improve those measures and figure out what's going on. What is a performance standard? A level of quality or attainment. Standards are similar to targets, but they apply here and now. If you go in and look at these measure specification sheets, you will find out these are what I think are the important things to focus on, because if you're looking at your 10 pages of information and they have flow charts and everything like that, you will find out each measure has a description, which is a brief narrative description of the measure. It has a denominator, which describes eligible cases for the measure, including patient population and/or patient demographics. Some of them, or most of them, have denominator exclusions. Certain populations may be excluded from the measure. For example, under BMI, you will not basically want OB population in that specific measure, and that is excluded. The numerator is the specific clinical action required by the measure for reporting performance. It can, it's a particular service or outcome. Reporting frequency, how often does the eligible clinician need to report the measure? In other words, for example, BMI, you're actually obtaining the BMI at each visit. Some other ones could be mammo, would be done once a year. The performance timeline, some quality measures have a designated time frame when the measure should be completed. For example, providing a flu shot, there's a time period from when the flu season's in before it starts and at the end, and that measure only looks at those specific months. Here's a couple of examples, and I'm not going to go through this. This is a very busy screen. I'm not going to go through this in detail, but I just wanted to give you a couple of them if you're looking at examples. You can see there's a description there, and it talks about at every visit capturing medications and making sure that it's documented in the chart. One thing that I want to say to everybody, this list must include all known prescriptions, over-the-counter, herbals, and vitamin, minerals, dietary supplements, and must contain the medication's name, dosage, frequency, and route of administration. And the reason why I'm saying that is a lot of times in the EHRs, you actually go and review that with your patient, but the thing that counts is at the end where you say, did you do this, and you have to do a check mark. So if that check mark, even though you did a thorough job in reviewing all that information, isn't checked, then you won't get credit for that. The denominator, again, they specify what CPT or HCPCS codes must be on that count to be in the denominator. In this case, if exclusions are if the patient's urgent or emergent medical situation where time is of essence, and to delay treatment would jeopardize the patient's health status. So, there is where if you have an emergency or something going on there, you do not have to collect that information in the denominator. The numerator eligible clinician attests to documenting, updating, or reviewing a patient's current medication using all resources available on the date of the encounter. And again, I reiterated that it must include everything. The reporting frequency, each visit, and the reporting time frame, 12-month reporting period. Another example that a lot of practices use is the BMI screening and follow-up. I know some of these could be used by the ACOs. Some of these private physician practices may be using some of these measures, but these two measures that I'm reporting are very common. This description, again, is those patients that are 18 years and older and with a BMI document. And most of the time, in most systems, if you put in their weight and height, the system will automatically document that BMI. And that's fantastic. But this specific measure wants you to also, even if it's documenting it, they want to make sure you have a follow-up plan for patients who are not in the normal parameters. So a lot of times when I talk to a practice, that's what holds it up, is basically the percentage doesn't go up because there's not a way of, they're not documenting the plan. Again, the denominator is all visits with double dose CPT and hip codes. The exclusions, basically there's a couple exclusions: patients receiving palliative care, patients who are pregnant, and patients who refuse measurement of height and weight or refuse follow-up. They should be excluded in the denominator. Again, the numerator: patient with a documented BMI during an encounter for the previous 6 months, and when the BMI is outside normal parameters. And there on the bottom, I defined what normal parameters are. Okay, I'm going to transfer it back over to Kaylin, and we have another polling question.
Okay, our last polling question is, has your practice selected your 6 quality measures for 2017? Yes, no, or yes, you guys have selected more than 6, but will report on the best 6 measures that you have. See if we can get a couple more votes. Then we have about 61% voted at this time. Okay, I'm going to close that and share those results. We had 33% say yes, 10% have not yet, and 57% said yes, that they had more than 6, but no report on the best 6 measures.
I think that's excellent. I will tell you that if we get practices to report on more than 6 measures, and if for some reason there's an issue with their system or anything like that, they can take the top 6 that have the highest percentage of the best. Some of them have to have the lowest percentage, but the best outcome. And then report that, and that will help you on your MIT score. Thanks, Katie. Okay, this is a form that we developed at Health Visions Delmarva. When we first go into a practice, we find out that a lot of practices don't know that they can pull data out of their system or don't know how to pull data. And what we are trying to do to see if we can make sure you can get information is to ask you to complete this form. And some systems don't even allow you to do a to and a from, like if you want to do a quarterly date, to and a from. Some systems have standardized reports and some have customized, have a report writer. I think if you looked at Dr. Sobel's presentation, he was showing you a report writer out of Allscripts. They had some standard reports, but the report writer, they can go into detail on some specific clinical data. Does your system EHR allow you to choose certain measures? We have found out that some EHRs don't allow you to do the entire 300, I think it's 273 measures. They only have specific ones you can do. A lot of EHRs have dashboards of measures, and I think a lot of practices are working with their EHR vendor right now to actually have it set up in their EHR so they can start monitoring. So they're asking them to actually define their 6 measures. If you can get more measures on those dashboard, again, that would be great, because then you can see which ones you're doing well at, and with 6 you want to submit to CMS. And then basically we were asking how they're currently sending in their 2016 meaningful use PQRS data, so that we would know, well, will they continue doing it that way, or are they going to do it some other way with an outside company or through their EHR vendor, or maybe acquire a registry. I will tell you that registries are better, I think, because in the long run, you can actually add things to the registry that may not be documented into your EHR. I've been more on the inpatient side of healthcare, and remember all the codes that medical records used to have. They were always looking at the chart and actually coding from that chart so that they could get information out of their system. And then just for information, we want to know what the certification level of your EHR is at. Define how to capture. This is another form that we use to capture your measures in your EHR. We would like, when you, depending upon if you have 6 measures or more, you really need to go through this form and define what field in the EHR is it going to be completed. Then contents required it to count as a positive result. It could be a check. It could just be an alphanumeric in a field that would be a positive result. If it's blank, then the negative result is not going to be reported. And then how reported PQRS or emits direct from the EHR or via registry. Again, a lot of people reported the EHR measures last year, but now a lot of these EHR vendors are now moving it into a registry. So you have to really know and ask your EHR vendor, are you actually going to use it, reporting it from the EHR, or are you importing it into a registry? And you would be surprised, there's a lot of that are reporting it into a registry. And the measure 128 BMI screening and follow-up, I mean, basically after height and weight is put in, most of the EHRs are calculating the BMI. And then there's a place for a BMI follow-up plan. And again, it may not be spelled out that way, but in this particular example, that's how it was spelled out. It may just look for, with the BMI, a calculated number in that field, and then an alphanumeric entry in the BMI follow-up plan. Again, this is one where the EHR is importing information into a registry, and then these are the fields in the registry: BMI follow-up plan. And if you notice on this, you have access to that registry. So if you're not capturing something in your EHR, you should be able to update your registry. And again, the content required to count as a positive result is alphanumeric entry in the BMI field and the BMI follow-up plan. Select measures for 2017. Just to repeat, select at least 6 quality measures. And again, you can go to QPP website to look at that, your selection. Select measures that are applicable with your specialty. Because if you're an endocrinologist, you would like to be compared against other endocrinologists and those specific measures. Review quality measure specification sheets. Again, I know they're difficult to review, but please review them. Check measure type to ensure you have selected at least one outcome or high priority measure. Again, in 2017, you have to have at least one outcome or a high priority measure. Check submission measure for each, check submission method for each measure. You must submit all quality measures using the same method. So if you're going to submit as to the EHR vendor, you must have measures that are applicable to the EHR. If you're going to submit measures that are coming from the registry, you must also have that particular measure must say registry on the submission record, and all must be the same. Review numerator and denominators and codes for each measure. Check to see if benchmarks are available for each measure. You have a potential to earn more quality points if a benchmark exists. For example, if you don't have a benchmark, you only get 3 points. Now, as time goes on, I'm sure there'll be more benchmarks created for more measures. But at this particular point in time, if you look out on that benchmark and your measure that you selected is not in there, there's no benchmark, so you only get 3 points. So you may want to select another measure. Check to see if the measure is topped out. If so, topped out means there's a lot of practices that are submitting that measure. So it may be more difficult to earn quality points. So I will tell you, one measure that I looked at, you had to have 100% to get 10 points. Everything else, and you could have been down to 99.9 and you would only get 5 points. So you really have to look at that. Compare your previous performance, what you submitted for PQRS measures, to your 2016 benchmark. So if you take a look at those that information, you'll see how well you were performing. Here's an example of a tool that you can use, and it actually goes down by the physician's name and actually looks at a specific measure and calculates or takes a look at the benchmarks comparing each physician in that measure. And this would be information that you could use to see if there's specific physicians or physicians that should be improving in their marks. So you can see it can go from, and you got Dr. E here that is getting 10 points. So you may want to talk to Dr. E and say, how can we get all the other doctors to be doing what they need to be doing? Summary of this whole thing. To transform data into meaningful information, practices must collect structured and accurate information. This is really important. Accurate information, you really want your measures to show what you're really doing. To show improvement in your measures, practice should understand the definition of measures, the numerator, denominator, and what patient data is excluded from the measure. If you go into an OB practice and they're actually selected the measure of BMI and follow-up plan, well, a lot of your OB patients will not be included in that measure. So is that a good measure for you or not? Practices must have an understanding of where to document in their EHR so that patient data is counted in that measure. It's important. You have to talk to your EHR vendor and say, we're not getting good percentages on this, so why are we not documenting in the right area, and where should we be documenting? Practices must review their quality measures at least quarterly, or they should do that. Compare the percentages to the benchmark, review their processes, and make changes in order to improve them. Use quality metrics to show your quality of patient care that you provide and how it compares to other practices. Okay, I'm going to turn it over to Kaylin.
At this time, we're going to ask anyone who has any questions to go ahead and either use the raise hand icon and I can unmute your line, or you can submit questions to the chat box and I can have Dr. Sobel and Barbara answer them. I know that we had a couple resources that were used during today's presentation, so I'll leave these up for a minute. I actually have someone who wants to unmute their line. Oh, maybe not. Maybe they went away. Well, I had someone who raised their hand, but maybe not. Here, I have a question here. How can we find out how to enter the necessary measure information in our EHR?
Well, what you have to do there is look at your measure. You have to go to those measure sheets to see what the explanation is, what should be in the numerator and denominator. You're probably going to have to call your vendor and ask them, where do I document to get this measure having a positive outcome?
Okay. I'm actually going to also switch over here. We have a part 2 that's going to be coming up, I believe, is it next week?
Next Thursday.
Next Thursday. So have some information for that. Another question we have is, what registry allows you to enter data that is not supported by the medical record? Isn't this a violation?
I'd have to look it up. I would think that if the registry, I mean, if anybody's adding information into your registry, it should be coming from documented in your medical record. It may not be in the right field, so they're adding it into the registry so they can get that measure to be able to look good. But basically, it has to be documented into your medical record.
And all the questions from today actually will have follow-up. We'll send out a follow-up email with more detailed information. Here's another question. Can we submit more than 6 measures?
Well, you can. I mean, the government's not going to disallow you to submit more than 6 measures. The problem is, what you want to do is probably collect information on more than 6 measures and then take a look at where you have high scores and basically select those 6 measures that have the highest score. I will tell you, to send more than 6 measures in, the government then will actually choose the best scores, but do you really want to have them have the choice of choosing what measures you're going to have your score calculated on?
I'm going to wait for a couple more questions to come in. Also, I'd like to put up all of Health Vision Somarva's team contacts. A couple of your advisors may be up here. Also, Dr. Sobel's contact. Dr. Sobel, did you have any closing thoughts for today?
No, I didn't. I think we've covered the topic pretty well.
Yeah, thank you. All right. Well, I'll leave the line open for the next, I guess, 2 or 3 minutes. And I want to thank everyone. Oh, we do have a question. Are we able to get a copy of Barbara's slides? Yes, I will be sending out an email. I usually attach them to the webinar, but today I did not. I will send out an email with the slide deck from today. Same with next week's. All slide decks will be emailed out.
I have a couple comments. I don't know if a lot of people have looked at their QR/UR reports, but that's a good way of knowing where you were from last year. Basically, if you looked at your QR/UR reports and you weren't scoring average or above average, there's probably things you need to do to improve. It will show your measures there, in the past PPRS measures, and basically where you actually compare to your benchmark. It's basically a good way of knowing where you're at today to see where you want to improve in the future.
Well, I want to thank everyone for joining us today. Thank you, Dr. Sobel and Barbara, for your time in presenting. And I will be sending out an invite to next week's event and ask everyone to join us again. Again, thank you, everyone. This will conclude